All right. So, welcome. I did my presentation on temporal bone fractures, labyrinthitis, and vestibular neuritis. So we're going to go ahead and start with temporal bone fractures. So a temporal bone fracture is the consequence of trauma, and we are concerned with it as audiologists because it can cause auditory and vestibular intrusions or dysfunction with symptoms as a direct effect of the severity and the location of the fracture. There are different ways to classify temporal bone fractures that I'll go into in more detail later. But the classical method of identification is relative to the plane of the petrous ridge. So longitudinal fractures typically follow a lateral blow to the head, and it follows the external auditory canal and rarely involves the otic capsule or facial nerve. And the otic capsule is another term for the osseous or bony labyrinth. A transverse fracture is a bit more serious for the auditory and vestibular dysfunction. It follows a posterior or anterior location of force and involves trauma to the otic capsule typically, with the potential to cause facial nerve paralysis, dizziness, and hearing loss of cochlear origin. When you get hit in the head with something, we can classify it as blunt or penetrating. So blunt is force without remains of debris, such as a baseball bat, which I know isn't a really great image, versus the insertion of an object itself, like a pencil, bullet, or metal scrap following a car accident. So when they present at the emergency room, that is definitely the first priority to get whatever material that is out. And now it appears that we're moving into new classification of otic capsule sparing versus involving, violating, disrupting. There's a lot of different synonyms for that. But it's because directionally, longitudinal versus transverse, sometimes it is mixed. And so they're moving into classifying it more as what the consequences are in relation to the otic capsule. So motor vehicle accidents are definitely the most prevalent when it comes to head injuries in general and can cause about 31% of all temporal bone fractures. And it also should be noted that new statistics are coming out that in urban areas, fractures caused by physical assault have increased. Other known causes: falls, motorcycle accidents, pedestrian injuries, bicycle accidents, sports injuries, gunshot wounds, really any way that you can hit your head, which there's a variety of ways. 30% of head trauma incidents result in skull-base fractures, and 14 to 22% of these fractures result in temporal bone injuries. So they aren't as prevalent, but there is definitely a higher chance for it with skull-base fractures. Men aged 21 to 30 are the most prevalent group affected by these because of the riskier behavior. If we're going with the classical way to describe fractures, 80% are longitudinal, 20% are transverse in nature, but 62 to 90% of fractures have been observed as mixed or oblique in terms of the directional patterning, which is why, which I just spoke about, the new classification of otic capsule sparing or violating have become more prevalent. So if we're going with those classifications, 95% of cases are said to be otic capsule sparing, 5% violating, which is good because violating is more serious, for us at least. And 8 to 29% of fractures cause bilateral complications, but the majority are isolated to one side. Some more information about pediatrics. So 8 to 22% of the entire population of fractures is comprised of pediatric cases, more commonly under the age of 6. So these present with a relatively high incidence, 58%, of intracranial complications, with about 3 to 9% resulting in facial nerve paralysis, mostly due to motor vehicle accidents, some due to falls, 40%. Similar statistics with longitudinal versus transverse. And it is good because the otic capsule is reportedly spared in 90% of cases. And hearing loss has been reported as conductive most of the time, 17% sensorineural, and 10% as mixed. So the thickest part of the skull base is that petrous portion, which is where the otic capsule is. So it does take a lot of force to cause damage to the temporal bones. And there have been some loading studies on quote-unquote fresh cadavers, and it said that it required, with lateral impact, 1,300 to 1,800 pounds of force, which is a lot to cause that damage. And as I stated earlier, most fractures are longitudinal and otic capsule sparing because they tend to follow the bone line of the native foramina within the temporal bone, kind of like a perforation of sorts. And 60% of fractures are defined as open, which result in blood, cerebrospinal fluid, fistula, brain herniation, or otorrhea. And it should be noted that these patients are at a higher risk of meningitis because that intracranial space is exposed. We'll talk about that too a little later. So the pathogenesis really is dependent on the severity and the location of the fracture. And there's a variety of outcomes of damage to the auditory and vestibular system and more. So if we're looking at the outer or middle ear space, the external auditory canal can be damaged, the tympanic membrane, you can have a perforation or hemotympanum, and the ossicular chain can be disarticulated, the inner ear, the cochlear and vestibule, nerves that can be damaged in a variety of ways, facial nerve, vestibular cochlear, lower cranial nerves, also the temporal mandibular joint, which can cause perception of tinnitus or jaw issues, really serious parts of damage, the jugular vein or the carotid artery, which can be catastrophic, so you can bleed out. And spinal injuries may take priority, as that's pretty important. And other issues that can happen: intracranial hematoma, contusion, edema, herniation, or a CSF fistula. Risk factors. In general, risky or reckless behavior. Obviously, there's always room for error with a fall, or even if you aren't, there's typically someone in a position of innocence in a motor vehicle accident, but in general, those are your risk factors for a temporal bone fracture. So we're going to go into a little bit more about the specifics and classifications. So with a longitudinal or otic capsule sparing, I'm going to put them together for the sake of simplicity. So as I said before, it typically follows a hit in the lateral direction to the temporal parietal region. And the path of the fracture, you can see it in this photo, in this imaging, runs anterolaterally to the otic capsule. And it typically has to do with an acute event that's observed in the emergency room directly following as the first step. And for this type of fracture, common auditory presentations of the outer middle ear, like hemotympanum, perforation, ossicular change, disarticulation, and a conductive or possibly mixed hearing loss. And other indications: battle wound, ear canal laceration, brain hemorrhage, dizziness, imbalance, or disorientation, a concussion. So even if it is otic capsule sparing, they still can have some vestibular issues, because when you're hit in the head, if you get a concussion or anything like that, it can cause you to be disoriented or off balance, even if your semicircular canals are not affected directly. So here are a couple pictures. On the left is a hemotympanum, which basically tells you that there's blood in the tympanic cavity. And on the right is a diastasis up there. You can kind of see up on the top that there is a fracture coming into right next to that middle ear space. And now, as far as grouping the transverse or otic capsule violating, it typically follows a hit in the occipital or frontal region and runs directly through the otic capsule, possibly the internal auditory canal, disrupting various cranial nerves, which we know run through there. Again, like the prior classification, typically an acute presentation in the emergency room. And auditory or vestibular presentations, severe to profound sensory neural hearing loss, because it really just goes right through that bony labyrinth and disrupts it. Severe vertigo and nystagmus, whose intensity will decrease after about 7 to 10 days, with lingering unsteadiness for about 3 to 6 months until compensation occurs. And mixed hearing losses are possible, but rare, typically from disruption of that ossicular chain. Other complications: 50% of cases have facial nerve disruption, which is permanent and immediate, especially if it runs right through that internal auditory canal. Cerebrospinal fluid otorrhea, intracranial bleeding, perilymph fistula, or an arterial or venous injury. So, as far as medical management goes, it's really important to note that patients typically have multiple injuries and complications, so it's most important to make sure that the patient is stabilized, especially following trauma such as a gunshot wound. So making sure that all their vitals are okay, checking that they have hearing loss will come a little bit later after they have stabilized. So the initial team of emergency physicians, nurses, and neurosurgeons and neurologists should, as far as auditory complications go, should check for the external canal status for blood or a CSF leak. And the status of the facial nerve is really important. So to establish if surgery should be done, you have to observe if the injury is recoverable or unrecoverable. And the degree of the injury should be analyzed there's a variety of ways to check: the Hilger facial nerve stimulator, electroneuronography, or electromyography. And a complete neuroaudiologic exam, nose and throat, nystagmus check, to see if the origin is peripheral or central. of dizziness if they are having dizziness, and definitely checking the site of impact and the auricles for hematomas or lacerations. You don't want any infections there. And cross-sectional imaging should and is typically completed. So as a standard trauma procedure, a CT scan is best for the path of the fracture or a foreign body, and then an MRI can be useful to check for injuries of the cranial nerves, temporal lobe contusions, or any other intracranial injuries following this damage. So it's good to know that cerebrospinal fluid leaks are acquired in about 17% of temporal bone fractures and are one of the most serious complications due to the risk of meningitis, which ranges from 2 to 88%, which is a really big range, but we know that whenever that space is open, that meningitis is a risk factor. So otorrhea or rhinorrhea, which would be CSF leakage out of the nose with a dull bilateral headache, is a symptom. And a 7 to 10 day persistent fistula, operation is indicated to close, and that's determined by the location of the fistula. So persistent middle ear cavity, tympanic membrane, or external auditory canal damage puts the patient at risk of long-term injuries such as external auditory canal stenosis or a cholesteatoma, which isn't typically something that I thought about with a temporal bone fracture, but if they do have that chronic perf or complication in that middle ear cavity, a cholesteatoma is possible. And antibiotics typically aren't recommended other than for contamination. So as far as audiologic management at the hospital, tuning fork tests can be administered and oftentimes are. And when or if the patient has the ability to travel to see an audiologist and they are concerned about their hearing loss, a full behavioral test battery should be conducted: tympanometry, acoustic reflexes, speech and air, bone conduction, otoacoustic emissions, and auditory brainstem testing can be indicated if they are not able to respond or complete behavioral testing appropriately. So as far as management for otic capsule sparing or longitudinal, they typically present with a conductive or a mixed loss. So middle ear surgery or exploration is pursued if a 30 dB HL airbone gap persists for longer than 2 months after the incident. And as our job, it's good to monitor and also give patients the options for amplification, like a bone-anchored hearing aid, cross, or a regular hearing aid, and talk to them about all of the different options with a conductive or mixed loss and the nature of that, and follow them through that treatment. So with otic capsule violating, it's typically a pretty severe sensory neural hearing loss. So we are in charge of monitoring for stability and speaking about all the amplification options, including cochlear implants if criteria is met, unilateral hearing aid if it's just that one side that can be aided across if they did suffer single-sided deafness after this, or an unaidable loss, or possibly a unilateral cochlear implant for that single-sided deafness, and careful evaluation for the threat of meningitis should be undertaken, especially if implantation is considered, because as we know, there are cochlear complications where meningitis is concerned, and typically patients are fast-tracked for implantation. So as far as vestibular management goes, the emergency medical professionals can check for nystagmus and have some knowledge with that for side-specific peripheral or central origin with bedside testing, and a couple types of insults resulting from fractures: BPPV, damage to the eighth nerve, paralimb fistula, traumatic endolymphatic hydrops, central origin issues if a concussion was suffered, or more complex intracranial damage. Spinal injuries can lead to coordination or imbalance issues. And once the patient stabilized, a full vestibular assessment can be conducted by an audiologist to assess the nature and severity of that function and then recommend for physical therapy or do the epi or take that a step at a time. So as far as differential diagnosis goes, case history is really important, and visible wounds, so that will tell you that they did fall and hurt something. Imaging to analyze the direction of the fracture and the degree of damage, and seeing what kind of loss they have, because that can tell you a lot. And also doing vestibular testing or bedside results to check if the damage has to do with peripheral or central. All right, so now we're moving on to labyrinthitis and vestibular neuritis. So labyrinthitis is an inflammatory disorder of the inner ear that affects the system of hearing and balance, encompassing the entire labyrinth. So typically it only affects one ear, but it can be bilateral, and it presents as an acute onset of true vertigo and sudden hearing loss typically following a patient having an upper respiratory infection or feeling sick. And the biggest difference with vestibular neuritis, it's a disorder of the vestibular portion of the eighth cranial nerve, so it only affects the patient's system of balance with preserved hearing status, and that is the best way to differentiate between the two. It can be inflammatory, but it's not as clear, so sometimes it is referred to as vestibular neuropathy. But the onset, as far as vestibular symptoms go, is acute as well, and typically involves true vertigo, nausea, vomiting, and admission to an emergency clinic. So we'll start with labyrinthitis. So the labyrinth is comprised of the four main sensory organs: utricle, saccule, semicircular canals, and the cochlea, located within the petrous portion of the temporal bone. And it connects the central nervous system through the internal auditory canal and the cochlear aqueduct. So bacterial or viral agents can infect through those pathways, the internal auditory canal and cochlear aqueduct. And autoimmune causes are also possible for labyrinthitis. So this is more for a reference for the etiology, bacterial versus viral. So you can take this with you, but most of them are for the viral ones that stick out: mumps, CMV, rubella, herpes simplex virus 1. So viral labyrinthitis so these infections can cause congenital or acquired labyrinthine infections, as well as idiopathic or sudden sensorineural hearing loss. So rubella and CMV are common prenatal causes of hearing loss, whereas mumps and measles more postnatal. And the inflammatory proteins gain entrance to the labyrinth by way of the round or oval windows, internal auditory canal or cochlear aqueduct, like we said earlier. So Ramsay-Hunt syndrome, which has to do with that herpes simplex virus, is caused by a reactivation of the dormant virus following primary infection, because that virus typically is laying dormant and not causing any harm in a lot of people. And this virus attacks the spiral and vestibular ganglion, as well as cochlear or vestibular portions of the eighth cranial nerve. And it's typically accompanied by facial paralysis and the vesicular rash. So it was interesting to learn about bacterial labyrinthitis and the different kinds because I wasn't as aware of it. And it can be a possible consequence of otitis media or bacterial meningitis. And the symptoms are a profound sensorineural hearing loss, severe vertigo, nausea, emesis, and ataxia. So suppurative labyrinthitis can be caused by meningitis and can spread from the cerebrospinal fluid, again through that IAC or cochlear aqueduct. And middle ear or mastoid infections that are commonly associated with a cholesteatoma can cause that dehiscent semicircular canal from erosion from this cholesteatoma, and can also cause that labyrinthitis ossificans, which is, again, what we spoke about earlier, why most patients are fast-tracked with a cochlear implant from meningitis, because it can cause that ossification. And serous labyrinthitis is mostly associated with complications from otitis media, and those toxins gain entrance through the round window, infecting the scala tympani, and the endolymph is infected at the basal turn of the cochlea, so it causes more of a mild or moderate high frequency sensorineural hearing loss. And the study by Kaya et al. Showed that there's a significant loss of outer hair cells in the basal and lower middle cochlear turns, as well as a higher prevalence of endolymphatic hydrops that's likely associated with that imbalance in the endolymph. So viral labyrinthitis is the most common that we see in the adult population and is very rare in children. So about 50% following an upper respiratory infection. 1 in 10,000 patients report sudden sensory neural hearing loss, with 40% also suffering from vestibular issues. And both suppurative and serous bacterial labyrinthitis is more common in the pediatric population, and suppurative is more prevalent under 2 years old due to complications with meningitis, but it should be noted that in the post-antibiotic era, suppurative labyrinthitis is rare. So risk factors: untreated or recent chronic middle ear infections or upper respiratory infections, pre- or postnatal viral infections, such as what we spoke about before, CMV, rubella, mumps, allergies that can lead to those upper respiratory infections, heavy alcohol consumption or smoking, I believe just due to the immunodepressant nature, an autoimmune disease or a compromised immune system, or the use of certain immunocompromising or ototoxic medications. So as far as medical management goes for viral labyrinthitis, antihistamine or antiemetic medication to treat the acute vertiginous symptoms, and then intravenous fluids if necessary at this stage. So these are typically administered in that emergency setting. benzo, and as well as the benzodiazepine for suppression of vestibular system or some sort of a sedative. Typically, oral or intratympanic corticosteroids or antiviral medication, or a combination of the two, is given. Bed rest and hydration, and then monitoring for worsening or changing symptoms. So for bacterial labyrinthitis, again, pretty similar for the initial acute stage, but for this it's a little different because you want to treat the underlying cause of that middle ear effusion or infection. You don't cholesteatoma, meningitis, and a consultation with a neurosurgeon if intracranial complications are found. And vestibular therapy for outpatient care, and then considering imagery for possible meningitic complications like that ossification of the labyrinth, or an MRI to rule out any retrocochlear abnormalities. So for audiologic management, once the patient's stable, should give a full audiologic test battery. And again, like the temporal bone fracture, if for any reason that patient isn't able to respond behaviorally in ABR, autoacoustic emission, and any other objective measures should be taken. So for amplification for viral labyrinthitis, you typically have a mild to moderate high frequency unilateral sensorineural hearing loss. So standard amplification in that affected ear should be considered. If there's no change in that hearing level. Suppurative labyrinthitis, it's typically a more severe to profound unilateral hearing loss. And again, you would take those precautions if meningitis was suspected. For serious labyrinthitis, that high frequency unilateral sensorineural hearing loss, that can have a conductive component if that middle ear effusion or complication still persists. So bone anchor devices, standard amplification, cross systems, all of that should be discussed. And as far as vestibular management goes, once a patient does recover from those acute symptoms, a full vestibular assessment should be conducted, and those proper referrals should be made for vestibular physical therapy if that imbalance persists. So as far as clinical and differential diagnosis goes, case history always really important, asking if they've had a sudden change in their balance and asking if they've been sick before are all nuances that can tell you a lot of information. A sudden onset of true vertigo and a typically unilateral decrease in hearing sensitivity. So as far as how it presents, it typically is really frightening for a patient. It lasts for over 20 minutes, and they typically go to the emergency room where the medication and fluids that we spoke about earlier are administered, and they're evaluated for head trauma, signs of stroke, cardiovascular complications, dehydration, and anxiety. So those things should be ruled out before they come in to see you. And symptoms do tend to improve over the next 2 to 3 days, and they have some time with lingering unsteadiness. So we're going to take a look at vestibular neuritis. It's in a lot of literature, they do group them together. As we spoke about before, one of the biggest defining differences with vestibular neuritis and labyrinthitis is that preservation of hearing status with vestibular neuritis. So typically for etiology, it's thought to be viral, mostly a cause of the herpes simplex virus type 1. People have also favored labyrinthine ischemia in the past, or it can be idiopathic, kind of like how sudden sensorineural hearing loss is. Pathogenesis, It's typically preceded by an upper respiratory infection like labyrinthitis and atrophy or inflammation of that vestibular nerve following the reactivation of that dormant HSV1 virus. And in studies, they have found that herpes simplex virus 1, the DNA and RNA have been found in the human vestibular ganglia. And it's the third most common cause of peripheral vestibular vertigo. And there's about 3.5 per 100,000 cases, accounting for 7% of cases at outpatient clinics that deal with vestibular issues. And it accounts for 5.6% of emergency department cases of dizziness diagnosed as vestibular neuritis. So this is a quote that I thought was pretty clear. The most characteristic histopathology of vestibular neuritis in the human temporal bone is degeneration of the superior vestibular nerve and vestibular ganglion with variable involvement of the neuroepithelium of the end organs and a deficiency in the population of nerve fibers and microscopic findings of myelin degeneration. So you really do think the cytolesion of this as that vestibular portion of the eighth nerve, and it typically is the superior portion. So risk factors: compromised immune system, cardiovascular, Ramsay-Hunt syndrome, allergies, or more preference to getting sick. Medical management: so there's 3 portions. So symptomatic treatment, you're treating those acute symptoms, so anti-vertigo or emetic medication, sedatives, intravenous fluids. So for causal treatment, in a study by Strupp et al., treatment with corticosteroids in isolation improves symptoms with much more success than treatment with antiviral medication alone, and there wasn't a significant difference when the two were given together. So we spoke briefly earlier about the etiology and how it is really common for people to think of it as a disease or issue of viral origin. So it's interesting that corticosteroids show more of an effective treatment option than viral medication or even the two given together. And it is recommended that they have ongoing vestibular rehabilitation and physical therapy. And if you are 60 years or older, if symptoms are accompanied by a headache, stroke, or retrocochlear pathologies should be ruled out with imaging. So as far as the clinical or differential diagnosis, case history, again, if they were just sick, really diving into that episode of that acute, severe, persistent vertigo and looking into those peripheral vestibular signs, the horizontal spontaneous nystagmus towards the non-pathological ear that suppresses with visual fixation. Vertigo increases with head movement and lasts for over 20 minutes a day. Typically is the superior branch of the vestibular nerve is damaged or more affected. And again, just to nail in the point that vestibular systems are the only symptom, normal hearing sensitivity is preserved, so an audiologic test battery is recommended to rule out involvement of the cochlea. All right, so we're nearing the end here. We're going to dive into the case study. So ABC is a 39-year-old male referred to by his primary care physician following complaints of hearing decrease and dizziness. He reported episode of life-spinning vertigo that lasted about 5 hours before being admitted to the emergency room and was given medication but didn't really remember what that was. He said the sensation came out of nowhere. He fell over and hit his head, and he came back to consciousness in the waiting room with his roommate who brought him in. And he was released from care the next day. He felt kind of hungover, like he couldn't hear out of his left ear. And he's had a faint, high-pitched ringing in his left ear for the past 2 weeks that's kept him from sleeping well. He doesn't know if he suffered a concussion, but he still feels off balance. And he denied pain, oral fullness, family history of hearing loss, any other changes or pertinent medical diagnoses, and he reported having completely normal hearing sensitivity before, no tinnitus. So the audio, he has normal hearing sensitivity in his right ear, a mild to moderate high frequency sensory neural hearing loss in his left. His temps look good, and all present reflexes a little elevated on his left ipses, and autoacoustic emissions present and robust in the right, absent in the left, from 2 to 8,000 hertz. So bedside testing, ocular range of motion was normal, vertebral artery screening is normal. He had some spontaneous right beating nystagmus without fixation. Head impulse test positive, left head thrust, which tells us that it's likely the left side, and has a leftward deviation with Bakuda stepping, and had a sway on foam and fell with his eyes closed on foam, so can't really rely on his vestibular system right now. So V&G gaze testing had some right beating nystagmus seen in center gaze without fixation, which is a sign of peripheral lesion. 9 degrees seen in left gaze without fixation, and 12 in the right, which follows Alexander's law because he's been having right beating nystagmus, and when you look in the direction of the nystagmus, it gets stronger, and all of the nystagmus subsided with fixation, which is consistent with a peripheral lesion, and his optokinetics were within normal limits. Smooth pursuit and random saccade testing was within normal limits, so at this point, we're really not looking at something central. All of the signs are still pointing to peripheral, which is good because we're always looking at patterns. Positional testing. In 4 conditions, he had right beating nystagmus, so that is significant for something peripheral on the left side. Calorics, unilateral weakness, 72% in the left, which is huge. So this is all coming together nicely to tell us that his left vestibular functioning is a lot less. Ocular events at 100 dBHL at 500 hertz. Left is absent, right is present, and we know that ocular event shows the integrity of that superior vestibular nerve and that pathway. So the fact that his cervical vents are both present tells us that now we're narrowing this down even more, because we know that the left side is weak, but now it's telling us, okay, it's likely that superior vestibular nerve pathway. And his V-hit also ties into this pattern really nicely. His left laterals show low gain over and covert saccades, which tells us that he's getting into some compensation. And his left anterior, again, low gain with overt and covert saccades. And the left posterior is normal, and all of the rights are normal. So that also ties into our superior vestibular nerve pathway, which innervates with the anterior and lateral canals. So now that we're putting it all together, he's got an asymmetric hearing loss, sensory neural on the left, no evidence of a conductive or mixed component. His bedside testing points to a left hypofunction, no central involvement. Gaze testing, again, consistent with left peripheral hypofunction. unremarkable ocular motor V&G results, which again, nothing central going on. Positional testing is consistent with this left peripheral hypofunction. Caloric testing ties into that as well. The absent ocular vemp, again, is more specifically pointing to that superior vestibular nerve as the site of lesion. And low gain saccades in the left lateral and anterior canals are consistent with the OVEMP findings, as well as everything else. So, conclusions based on the vestibular and audiologic findings, along with the history, labyrinthitis of viral origin affecting the left side cannot be ruled out. So, how do we know that it's not vestibular neuritis? There is hearing loss and auditory involvement, and we know that that is preserved if it's vestibular neuritis, because it's only really the nerve that's affected. And how do we know that it's not a temporal bone fracture? Well, case history, but he also said that he fell because he was dizzy. So there could have been some sort of issue there, but there's no conductive or mixed component to the hearing loss. That sensorineural hearing loss is not profound. And the vestibular damage is isolated to that superior pathway of innervation, and everything isn't really severely damaged. And that is it. Thank you for listening, and I hope you have a good day.